COPD stands for C, chronic. That's a disease that you're going to go to bed with it, you're going to wake up with it, you're going to have it all day, go to bed, wake up next day. It's a chronic disease. It's not acute. So C stands for chronic. Obstructive, the O stands for obstructive. People with COPD can get air in their lungs, but they have a hard time getting air out. So there's an obstruction to flow of air out of the lungs. And many times, just this week alone, a new patient came and said, "Doc, I can't get the air in my lungs." And I said, well, the real problem is you can't get the air out. And if you can't get all the air out from one breath, there's no room for new air to come in with the next breath. So many times what the patients actually are experiencing is they say they can't get the air in. But the real problem with COPD, the O stands for obstruction. There's an obstruction to flow, so they can't get air out. And then the P stands for pulmonary, lungs, the D, disease, so COPD. COPD is defined by airway mechanics. What does that mean in English? We know that someone who can get air out of their lungs in a normal fashion should be able to get a certain amount of air out over a certain amount of time. And there's a machine, a device called a spirometer. And we can, with that device, determine if you're getting air out of your lungs in the time that you're supposed to be able to get it out. So if there's a delay of flow and it takes longer for you to get that air out of your lungs, that demonstrates the obstruction. 85-95% of patients with COPD, there's an identifiable smoking history. Either the patient themselves smoked, or they had significant secondhand smoke exposure. It's an unusual situation where I'll diagnose COPD in an individual who either didn't smoke or there's no historical history of significant secondhand smoke exposure. But it does happen. It does happen. So have I diagnosed COPD in patients that didn't smoke and I couldn't come up with a secondhand smoke environmental tobacco exposure? Yes, but it's unusual. COPD cannot be cured, but that doesn't mean that we cannot return a patient to a very high quality of life functioning. So the example I use with my patients is I have been wearing glasses since I was 10-ish, and I have 20/20 vision. If I take off my glasses, you're all fuzzy. I can see you, but you're all fuzzy. The point is, are the glasses a treatment or a cure? It's a treatment. It's a very effective treatment. And my quality of life is comparable to someone who doesn't need glasses. So it's the same thing with COPD. If you diagnose the disease correctly and you get appropriate treatment, you can significantly reduce the disability associated with the disease. What's most important to the patient is that, can you make me feel better, Dr. Seifer? Can I have a better quality of life? And every single patient that I see that I diagnose COPD, I promise them that I will get them to a higher level of functioning, that I will improve their quality of life. And time will tell how much ground we can gain back. But certainly, I've never met a COPD patient that I couldn't help them in some way.